Thank you. I hope everyone can hear me okay. Okay, great. So today I'm going to really give you more of an abstract picture on what health in all policies is. I'm going to cover some of the material from the chapter in health promotion in Canada. And the reason I'm going to keep things more abstract is because we will then hear about some actual examples from British Columbia in the second half of the webinar. And so, so forgive me if this all seems a bit abstract at first. I'm going to start here with sort of the rationale for working intersectorally if we want to really tackle the health gradient. The health gradient, of course, this is something that we've known about for decades now, and even the rationale I'll give you for health in all policies, I'm using a slide from 1988. So really just to make the point that this is nothing new. We've known for a long time that the health gradient it impacts us because of the burden, the cumulative burden of hazards that people experience the further down the ladder they are. And acting at the level of individuals through health promotion that really aims to prevent illness by convincing individuals to change their behaviors is simply not effective enough. It's necessary on one level, but it's not effective enough. And we know that because this gradient is being held up by a number of different issues that affect us and that disproportionately affect people lower down the ladder. So the environmental health hazards that you get by living closer to a factory or closer to a major roadway, the lack of education that you might experience, or at least the relative lack of education if you are an Indigenous child in this country because of differences in funding, for example, or if you live in a neighborhood in a city that just isn't well served by schools. I could keep going down this list, but we know that there are a number of issues outside of the control of individuals, but also outside of the healthcare system that are sort of buttressing this health gradient. And so what we really need is more action on these issues outside of the healthcare system if we're going to address the health gradient. And so this is where the idea of working intersectorally comes from, the need to sort of work with partners in all of these different sectors. And health in all policies really comes from the idea that governments specifically play a key role in planning and managing what these sectors look like through their ministries or departments. And so the idea came about that, well, maybe governments should start working in a way that they coordinate policymaking across all of these sectors so that all of these sectors take health and equity into consideration as a part of their regular work. So there's really no cookbook on what health in all policies is. There's no sort of manual that you can use as a local or a federal government to say this is what you're going to do. Health in all policies is an idea, as I just described it, and every government that tries it has to come up with a model that's going to work for them. And that can be a little bit daunting, but that's why we're continuing to do research in this area to try and find some lessons for governments trying this out. I will say, though, that if there's not a cookbook, there do seem to be some key characteristics that that you find in a health in all policies initiative. And so I'll just go through those briefly. So first of all, there is intersectoral action happening in some way for health and hopefully health equity. Hopefully health equity is somewhere there either explicitly or implicitly through the way that intersectoral action is being done. And this intersectoral action is not ad hoc. It's not sort of a one-time deal. A process has been set in place where intersectoral action is happening durably, possibly even systematically. So the idea of health in all policies, some people might hear that and think, oh, each and every policy that a government makes is going to be considered. And some health in all policies initiatives do try that. They do try to set something up where systematically all policies are being shaped. Whereas in other cases, it's a little bit more selective, maybe driven by a particular strategy, which sectors are going to be and which policies are going to be subject to this process. The second characteristic would be that policy coordination is happening sort of within a government, but also across levels of government. So we all know that the social determinants of health are not shaped just by one level of government. And so if you, say if you're working at the local level and you want health in all policies to improve health equity, you're going to have to probably start engaging with governments at other levels as well. The third characteristic is, of course, that this is not just meant to improve the healthcare system and to make it more equitable. This is about focusing beyond the healthcare system. You could have partners from the healthcare sector engaged in health and all policies, but they're generally not leading the way. And that's why for health promotion folks, this is particularly relevant because in many cases it is health promotion relevant organizations that are leading the way within a government or even outside of the government. In Ontario, you'll see public health units that sometimes are arm's length from government but are leading this work. And finally, most health and all policies initiatives recognize the value of bringing evidence into the policymaking process. And so you'll usually find some tool or process for integrating evidence about, how to shape policies to make them more healthy or equitable. Okay, so the reason that I think health in all policies is so important is because it addresses what the World Health Organization described as the structural determinants of health. You'll notice that blue box on the right side, and that's all of that evidence and discourse that we've had about the social determinants of health. And this framework sort of highlights that, the distribution of those social determinants of health across a society, and therefore the creation of health inequities, is driven by everything on the left side of this figure, the structural determinants of health or the social determinants of health inequities. And as you can see on the left side of this figure, the role of government in terms of governance processes and specific types of policies that are produced by a government. Health in all policies really is a way to try and intervene on those factors in this framework. So it really is an intervention that aims to address the structural determinants. And that's why I think it's so important to work towards. It's important to work towards. It is really challenging to do. And this figure is just trying to sort of highlight that. Typically, I can't even really think of many governments that aren't traditionally like the left side of the figure there, which is a policy silo model where every sector or department or ministry or whatever they're called, they're housed in individual silos. They get a unique mandate, they get a unique budget, and they really just go to work on meeting their objectives. And really, health in all policies implies what we could call integrated governance. And so not only integrated, but putting health sort of at the center, at least in an abstract way. And this is challenging for a government to adapt to, because all of a sudden mandates start to overlap a little bit, and budgets start to become potentially maybe shared. And that can create all sorts of conflicts, which I'll talk about later on. But it's also just something really daunting to try to figure out how do you do this. Now, as I mentioned, health in all policies is not a cookbook approach, and so some governments have tried one way, other governments have tried another way. There's really so many different examples you could learn from about how you could do health in all policies in your government. And what this table is doing is just trying to highlight 4 different health governance approaches for doing health in all policies. This is not meant to be all of the possible health governance approaches to do health in all policies. It's just an example of 4 of them. So one approach would be to use tools like a health impact assessment tool to try and embed intersectoral action prospectively on potentially harmful policies or projects that are coming up. And this is the approach taken with the revision of the Public Health Act in 2003 in Quebec, and with the National Health Act in Thailand in 2007. And even those two initiatives are not very similar when you get down to the details of what they're doing, just to show you how different health and health policies is in every setting, but they still do sort of generally do the same kind of approach there on the right side. In Sweden and Finland, they basically they're not trying to embed health considerations into every new policy or project. They're really trying to coordinate intersectoral action to bear on a set of strategic health objectives that they've put together over a fixed period of time. So it's not a permanent change. It's more, usually it's a 10 or a 20-year strategy, and they're using health and health policies to say on these sort of strategic objectives, we're going to use intersectoral action to try and improve health equity over the next, short to mid-term. And so in Sweden and Finland, they both have strategies that they're using to guide where that intersectoral action happens. In California and Ecuador, they do a similar sort of thing to do health and health policies, but they're coordinating intersectoral action for some other purpose. It's not a health objective at the end of the day. They are trying to coordinate intersectoral action on health objectives, but it's to achieve something else that that the government has identified as a long-term strategic objective. So in California, they have been focusing on sustainability, and they're using health and health policies as a way to achieve that, one way to achieve that goal. And in Ecuador, they're trying to improve quality of life more generally, and they're using health and health policies as a way to achieve that. And then finally, just to sort of throw in a totally different model to show you that there are so many different potential health governance approaches. In Iran, the way that they do health and health policies works more to identify local needs at the community level as a starting point, and then that knowledge goes up to the government, and the government sort of says, okay, these are the local needs in that area. What could we do to improve conditions in that specific area? And so they're really working in a sort of bottom-up, top-down way to identify a series of specific needs across the country, and then coordinating to try and address a host of different objectives in different parts of the country. Okay, so health and all policies then, we're starting off with this sort of siloed model of governance that has usually been around for a long time. And you're trying to transform your government in a way to coordinate objectives. I told you this is going to be abstract, but hopefully this is making sense to you. And this is kind of what you want to try and construct within your government. And there's a number of challenges that go along with doing that we've identified and that others have identified, and that people who have tried to do, so it's not just researchers that have identified these challenges. When we talk to people doing health and health policies, we learn a lot about the challenges. And I'm going to tell you briefly with the rest of my time about some of the technical, political, and evaluation challenges that seem to pretty naturally arise if you're going to try using health and health policies. I'm going to tell you about some evidence that largely comes from a research project that I helped lead at the Center for Urban Health Solutions at St. Michael's Hospital called Harmonics. And our website is there if you want to sort of learn more about the project and see some of our other publications. So I'll start with some of the technical challenges, and this is really just giving you a flavor for these. You could look at the book chapter for more details on these chapters, on these challenges. Or even look at some of our other publications. So technical challenges. So the big question, if you're going to start to try to do health and health policies, is so how are you going to structure the civil service to do health and health policies? What new policies, what new processes are you going to make mandatory to build this into the civil service? And how are you going to support people to do this? So not everyone is naturally naturally is aware of the social determinants of health, or how work in their specific sector is going to impact on health and health equity. So you also have to think about how you can support people in your government to do this kind of work. And so some people have written about, the need for a supportive architecture, which is just, I think, a nice way to think about, what you need to introduce to do health and all policies if you want it to be sustained, this kind of intersectoral action. And this is just a range of some of the things you might need to think about from a technical standpoint. So you're going to want to have some sort of a mandate that is long-term in nature, so that it's not just an ad hoc project, and that after you do this one thing together, nobody needs to think about this anymore. So you want some sort of a mandate that will push you forward in the long term. Mind you, not every health and all policies case uses a mandate. I mean, there are some examples that I can think of. For example, in Peterborough, when they started doing this kind of work, it was really just being driven from the medical officer of health and sort of finding opportunities to do intersectoral action over time. But that's really because that was a sort of a leader who was able to sustain this over time. If you don't have a leader who's just going to, lead the way for this work, you need to sort of try to build in some sort of a long-term mandate. You need to have staffing and resources that are dedicated to health and all policies. It doesn't have to always be a huge amount of people, but there should be someone there whose job it is to think about this, because there is so much work to do, so many technical things to work out, so many political challenges to try and work through, that it is going to be a lot of work, and there should be someone dedicated to that, and they should have some resources to work on it over time. As I alluded to earlier, there's going to be a need for some awareness raising. So you're going to have to teach people in your government how to do health and all policies, how to think about the health impacts of their work, in other words. Usually there are some processes that are going to be brought in so that people who are doing policymaking, who are making decisions, understand how to do health and all policies. So a process is usually helpful to introduce. And that will usually involve, or sometimes I should say, will sometimes involve tools, governance tools, like impact assessment tools. So in Ontario, we have what's called a health equity impact assessment tool. And that could be a really useful tool for doing health and all policies in the province, for example, because it directs you to specifically consider the health equity impacts of a potential policy change or program change. And so it's a way to help people do the work of health and all policies. Those aren't all of the technical challenges, but these are some of the areas that we've learned about that seem to be really important to think about if you're going to start using health and all policies. I'll skip to evaluation next instead of the political challenges. Usually people who are going to use health and all policies find that other people in government want to know, why are they doing this, and is it working, and is it worth continuing to do over time? And so ideally you would be thinking about how to evaluate the work that you're doing so that you have evidence when you need it. And so you can think about this in terms of evaluating how health and all policies is impacting on health equity outcomes, but also what's often of interest to some people in government is the economic impacts of doing health and all policies. So is this different way of working actually saving us money? Because some people have sort of put forth the idea that, well, if you do health and all policies, it's going to lead, it is more health prevention work, and that is going to reduce the burden on the healthcare system. So do this so that it can help you deal with that other problem that everyone is thinking about. And so it could be helpful to have some economic evaluation built in as well. The challenges here are that impacts on health equity are on the mid to long term, really. If you start to change policies today, that's going to lead to people developing in a healthier environment, hopefully having better opportunities, and you're going to see impacts on equity down the road. So you want to think about how can you start to evaluate things more in the short term. What are the social, health, and economic outcomes that you expect to happen more quickly that would pave the way to impacts on health equity. And so logic models are your friend here. You want to try to think about the actions that you're doing in a very sort of logical way. What's going to change in the first 3 months? What's going to change in the next 6 months, in the next 2 years, in the next 5 years, that sort of a thing, so that you will know what to evaluate when, in other words. The other challenge that I've heard from policymakers is that when you have a whole bunch of activity happening in a government, lots of different interventions at once, and then you're trying to evaluate impacts on population health down the road, people want to know who gets credit for positive impacts. So when you work together as a team, you know, whose departments, policies, or programs had the most impact. So there's a real web of causation at work here because lots of things are typically happening in a health and health policies government. And so some people have suggested to think about collective impact models as a way to envision maybe not just trying to identify the individual contributions, but to conceptualize the work of government more collectively. So there are, you know, evaluation is really important, but there are a lot of challenges to doing both the health and economic side of that evaluation. And finally, there are political challenges to using health and health policies. And we've been focusing on this a lot lately in our work. And yeah, they really are inevitable, these political challenges. And so the more you can sort of prepare yourself for them, I think the better you can navigate your way through them. There's two types of political challenges I'll talk about. And the first is that since health and health policies is usually about health equity, there's that ideological commitment that we are all going to work together to improve the social determinants of health. And, you know, health equity implies a need for more social justice. And, you know, what if in some of the departments or ministries that you're working with, there's a conflicting ideology that's the norm? So maybe some people think that by contributing to a stronger, or not think that, but, you know, they see their role as growing the economy so that there'll be more opportunities for work so that there could be more health equity. And why are you asking me to work on, you know, on this in a different way than I'm used to? The other big conflicting ideology that we see is the one that, you know, most people in a society believe that the main determinants of health are their genetics, their lifestyle choices, and their healthcare, their access to healthcare. And so there might need to be some bridging of that gap as well, that by working in other sectors, we are actually doing we're still shaping the determinants of health in a really profound way. And so these political challenges about ideology tend to be about some awareness raising, some educating, but sometimes these are just unbridgeable. And you have to find ways to work together in spite of them. And I'll talk to you about how you might do that later. The other political challenge I'll talk about is about jurisdiction. So, you know, traditional siloed governments have clear boundaries around each sector, clear boundaries about, you know, what everyone's responsibility is, what their authority is over certain issues, and what funding they have to do their work. And so when you start to do more integrated governance, sectors can get protective about their resources and about their power over certain interests. So, for example, a partner that you're working with might really have the interests of an industrial partner in mind, and how, you know, their department might, their main objective might be to support the growth of a particular industrial partner. And if health and health policies imply some curtailing of the power of that industrial partner, or control or regulation over them, you know, that's going to create this sort of jurisdictional conflict. It could even just be more mundane issues about who gets to decide about how certain issues are debated on and policies developed about them. Certain checks and balances people can be protective over, or the budgets they're given. And so you have to find ways to work together through those types of jurisdictional conflicts. One of the ways that we have found in many case studies that seems to work is using a dual outcomes approach. So whether it's trying to bridge ideological gaps or jurisdictional conflicts, you can always try to find partners who are willing to work with you because they're still getting something out of it. So in other words, it doesn't have to be a zero-sum game. And so it's about trying to think about the dual outcomes that could come out of certain projects. I won't even go through this slide. It really just sets up a series of examples about how you could think about dual outcomes when working with different sectors. And the point here, I think, is that there's evidence that if you start to work with a partner in government on anything, just find something that you can agree on and that you're both willing to work on collaboratively. Doing that kind of work, even if it's not the most important issue to you or the most important one for improving health equity, you should see that as relationship building that will actually lead to ongoing collaborations with that particular partner, and over time opens the door to working on sort of deeper health equity interventions or things that are more important to you as a health promotion person. So just try to find something that you can work on in a collaborative way where there's clear dual outcomes. And over time, you'll find that it gets easier and easier to bring that partner in on the types of things that you really want to work on. And the last slide that I have for you today is, it's really a bit of a cautionary note. No, it's not really a cautionary note. It's to say that I think one of the real shortcomings of health and all policies to date has been that it is not as participatory as it should be. So health equity interventions, we know, need input from people in the community who are being affected. Whether you're thinking about what the problem is, whether you're thinking about how to think about solutions, you need community input. And most health and all policies initiatives that I've studied or read about do not have a role for community. I think particularly at the local level, there needs to be more integration of community partners into health and all policies. And the other side of that coin is that particularly at the local level, you're going to find that local businesses, chambers of commerce, partners from the private sector are also a part of the community that needs to be engaged. And that can introduce all sorts of potentially conflicting interests, although in my experience it's not as hard a hill to overcome as you might think, because many times community business leaders can see the long game and can see that sort of bird's eye view on population health once you teach it to them. And so it's about finding ways to have tables that can include the voices of people in your community, whether they're from NGOs or advocacy organizations or private businesses, and finding ways to make health and all policies work with those partners at the table. So I would sort of say that just to encourage you to particularly if you're at the local level and you're designing a health and all policies initiative, try to bring those voices in and not exclude them. And on that note, I will pass this on to my partner, Victoria Barr. And I'm not sure if I'm doing the introduction or...
No, I can do it, Ketan. Thank you.
Thank you.
You brought up some really interesting points that I'm hoping people will comment on in the chat box. And I'm especially interested in that discussion over power. The power, the thought about giving up power over resources and over interests, and what that means in an intersectoral space. So if people have some comments or some insights on that, that would be great. I'll encourage people to start thinking of questions for our speakers and post them in the chat box, and I can move them over and pose them to our speakers during the question-answer period. So thank you, Ketan. And with that, I'm going to introduce our next speaker, which is Victoria Barr,